as the weather forecasters repeatedly got it wrong day after day. And so, but we're so glad that you were able to join us, because I think this is an important beginning. It's an important beginning of a dialogue that I hope will extend far beyond this, in terms of being able to put on the table some of the issues that all of us have been debating in our own little MS and CCSVI communities, and now we have an opportunity to extend that to include some of the people that perhaps can influence the course of CCSVI in the future. And I put patients first and foremost in that circle of influence, because we certainly have proven that we can take it as far as we have. When I was drawing this meeting together, we were trying to decide, who should we invite and what representation we wanted from the various groups. And in here tonight, we do have healthcare providers, we have MS Society representatives, we have government representatives, we have physicians. And so we did get a broad spectrum of different groups, and of course I wanted patients to be one of the groups that was represented, but it struck me that we're all patients. Patience is something that we all have in common. Whether we have MS or we have something else, we're all patients. And this is a healthcare issue, and as such, it affects every single patient in Canada, whether that person has MS or CCSVI or any other thing. We all have a stake in having a sound and effective healthcare system in Canada. And this meeting is taking place in British Columbia because we are honored with the presence of Dr. Kirsty Duncan. We do have federal representation here that will allow us to take it to a broader context and not just deal with British Columbian issues, but deal with the national scope of where the national government could, the federal government could take a role. And, excuse me just a moment. Busy. Oh, and we're honored to, Dr. Duncan's just informed me that we have John Weston as well, who is the MP from Vancouver. And, with that, I guess, could I have Mr. Weston identify himself? I don't. Oh, there you are, right there. Okay, perfect. So at least I know where to look then. And with that, I will introduce the people that are sitting to my left. They're the people that have organized this and brought it together, and certainly have the impetus to have this meeting happen, and our special guests as well. So first, to my left is Dr. Kirsty Duncan. She's the MP from Etobicoke in Ontario. And if you are not aware of her, Kirsty's advocacy and interest in this matter, I'm sure that she will be more than willing to fill us in on what she's been doing over the past year or more to do exactly what we need from the federal government, and so we're very honored to have her tonight. Next to Kirsty is Dr. Bill Code. Dr. Bill is a friend of CCSVI and has both a personal and professional interest in this, and deals with many aspects of medicine. Began as an anesthesiologist, but is now more into holistic medicine, and chronic disease management is something that I'm looking for Dr. Code to bring to this tonight, as he helps us with looking at how physicians deal with chronic illness and some of the gaps and deficiencies in our system that this CCSVI issue has brought to light. And further down, we have Cheryl Otto. Those of you who were at last Tuesday's meeting, boy, Cheryl, you were just cranking out the meetings. Cheryl brought together 300 people in Vancouver to deal with CCSVI. We had an interventional radiologist there speaking about treatment. We had patients giving their testimonies on how they were doing post-treatment. And Dr. Code shared with us the fundamental of the condition of CCSVI. And so it was a very successful meeting to try to inform people about our experiences as patients. Next to Cheryl is Benita Boutilier. Benita is also a CCSVI patient who's being treated and shared her experiences. Last Tuesday, Benita is also organizing with us to try to bring CCSVI more into the forefront and get it off Facebook and more into the community and outreaching to groups such as this and beyond. And on the far, far left, bending over, Emily, now is it Hembroff Davis or, yes, sorry, I don't know. I know it on Facebook. That's the problem, is we know each other on Facebook and we, you see each other's pictures, they're thumbnail sized, and so it's a way for us to get to know each other in person now, which I think is important. Emily also is with our organizing group of patients, has a CCSVI treatment history herself, and is helping bring her expertise to getting this movement going forward in both British Columbia and Canada. With that, what the evening format is going to be is I've got a series of questions that came off Facebook. I asked several times for people to volunteer questions, and these questions came. So the questions came from the patients on Facebook. They came from some of the participants here said, I hope that you talk about X when they registered. And so I've drawn up a list of questions into 4 broad themes. We organized them into research, assessment, treatment, and then follow-up monitoring and care. And these are broad categories. If you want to go off in another direction, certainly if the interest and motivation to do so is there, I'm not going to come down on you, but I will be there to move the discussion forward and try to get through the list in as complete a way as we can. So I've just got to note that Dr. Godley is he on his way, or we're not sure? Is he lost? He could be lost. We are expecting Dr. Godley to come as well tonight. As you know, Dr. Godley is active in the assessment of CCSVI here in Vancouver and is currently completing an assessment study on CCSVI. So we're hoping that he gets here, but we understand that the conditions outside are pretty miserable for some people to get through the weather. Could be that. Anyway, with that, the format then is I'm going to have some questions that I first will ask some of the people sitting to my left to comment on as I go through the questions, and then throw it open to the floor to comment, and from there you can ask questions back to us here at this end of the room, or you can ask questions of each other, or you can simply make comment, whatever you feel like. This is a room built for dialogue, and I really hope that you feel open and feel that this is the place for this to happen. On that note, what we're looking at here is we're looking at the bigger issues of how to move this forward. There's a lot of history that's gone by with CCSVI, and a lot of people have very valid concerns about some of the history. However, if we spend a lot of time tonight on the history, we're not going to have a lot of time to move forward. So just, if you do want to engage in revisiting something that you feel has gone on in the past that you're not happy with, bear in mind that might be something better left for the after, into the reception area. If you do want to talk one-on-one with someone, feel free to carry that conversation on after we finish this main part of the session. If you want to speak, I guess there's, I can see everybody, so just raise your hand if you want to turn your mic on, and that way I'll just throw the floor to you and we can carry on. If you forget to turn your mic on, would the person next to you remind you to do it, and please turn it off. You can see by the little red light when you're finished speaking, please turn it off. So with that note, our first question deals with the research of CCSVI, and it really deals with why CCSVI has been linked at the hip with multiple sclerosis, and how all research that seems to be underway is to establish the scope and nature of the association with multiple sclerosis rather than deal with CCSVI as a separate vascular issue. And so I'm going to ask Dr. Duncan actually to be the first one to speak on this issue of you know, why is it so difficult for us to move beyond dealing with CCSVI as a separate issue? Why do we have to combine it with multiple sclerosis and get at that association before we can move forward with treatment of the condition itself? Thank you.
Thank you, Sandra, and I'd just like to say it's an absolute honor and pleasure to be here. I'd like you to know that working with many of you, and many of you I know from email or spoken with, has been one of the greatest and one of the greatest honors of my life, and one of the most humbling. I don't have an answer for what Sandra has just asked. The International Union of Phlebology came out last year and said CCSVI is its own condition. They did not make a link. In Parliament, I was able to start a subcommittee on neurological disease. In the spring, we did have the MS Society there, and I respect tremendously the work they do. But when I asked about that consensus document and how did they feel about the consensus document, the response I got was, what was that? There is a vascular problem here. Dr. Hakey out of Detroit has now identified 48 different vascular problems in the chest, neck, and spine. You may have a normal jugular on one side, the other one is string-like, or a normal jugular and a jugular that stops at the scapula. I've seen people who are actually born without jugular veins, or a normal jugular and a mass of spider veins. They wouldn't even know what to treat. And one of the reasons we need clinical trials is to figure out what can currently be treated and what can't be. And I'll stop there because I'll go ahead of you.
Thank you. And Dr. Coe, from a medical perspective, what is the complication with establishing something as a new condition? Have you seen that before in your past? And how do you put boundaries on something like CCSVI without complicating it with the somewhat familiar, which is MS at the moment?
I think the big challenge that we unfortunately run into in Canada is it's become all wrapped up in motion. And the subset of people, the neurologists, have become somehow very, very threatened. And they feel like they're backed in a corner. There's two in Calgary that I know personally because I trained with them when I did anesthesia there and brain research there in the 1990s. Now bodyguards. There's one in Ottawa with a bodyguard. And frankly, they've earned their bodyguards. They need them because people are really angry at them. But so, I think you're probably exactly right in that we need to sit back from this, and we need to sit back as a people. That is, because the physicians are pretty wrapped up in this now. They're now starting to wake up because they know that they're going to be liable and at risk financially for legal cases, such as the fellow who felt he had no choice and literally was told he had no choice. He went back to Costa Rica and died secondary to probably excess use of medication to dissolve the clot and bled internally. but none of that has been told to the press. None of that detail has come out. They'd like to make it that the treatment, angioplasty, caused the death, and it's not true at all. So, if I went in tomorrow with signs and symptoms of stroke, and lots of signs and symptoms of stroke are the same as MS, I would run the risk of not being treated because I have MS. And I used to do stroke research. I know quite a lot about stroke research. And it's a vascular issue. Yes, admittedly, it's primarily an issue in the arteries of the brain and the neck. However, it's also a venous issue. 40% of strokes come from the heart. That's because some of us have a crossover in the upper chambers of the heart, the atria. There's a hole. And so a clot from the veins can travel across that hole and then be transmitted up to the brain. And of course that clot, when it blocks an artery, causes lack of blood supply to that region of the brain, and you're suffering a stroke. So these are all intimately tied together, and we become for the second standard of practice, and that's completely unacceptable to me. It's unethical, it's immoral, and it's illegal. Maybe we're going to need to follow that path, and I'll be very interested in Cheryl's comments next. I think the other piece that we have to look back to when we're looking at the research, I think we have to look at the CCSVI component. If we say that that is a reason for the excess iron in the brain, because that excess iron in the brain is probably the trigger of many of the issues. It may be a problem equivalent to the autoimmune disease. It may be a piece of the autoimmune disease. It may be even its own entity. But if that excess iron in the brain is also found in Parkinson's and in Alzheimer's, now we've diffused the issue of MS. Because now we've got a whole new set of people in their lives. Now, admittedly, we're still dealing with the neurologists. The neurologists have always been the Sherlock Holmes of medicine. They're almost always right. And the reason they were almost always right when they diagnose something is they will wait 1, 2, and 10 years to diagnose it, because they never had anything to do at the end of the road anyway. That's true. You know, recently we got into brain attacks and treating stroke with blood clot dissolving medicines, okay? Interventional radiologists in Canada can do that. And we can dissolve those clots and thereby get rid of the stroke for up to 4 hours. And Dr. Hakey in Hamilton, also working in Detroit, has been one of the instrumental ones that made it, you could go 4 hours after your stroke and still be treated with clot dissolving. And yet, have we told the people in the emergency room that? Have we told the people in the public that? We have not. That's unconscionable. So, you know, I think if we're going to diffuse it from the medical side and the research aspect, I think we do have to try and make it its own illness. Because right now it's wrapped up in our emotion and passion. And I have every bit as much passion as you do. I'm having my angioplasty on Monday, all right? I believe very strongly in this. I've got a sister who, you know, is waiting to see what happens to me. And a young woman that works for me, the same thing. But I think we have to, medically, we have to look at it as its own entity and what is associated with it. Because when we say the studies show 56% of folks with MS have it, 25% of the regular population have it, why is there that crossover? Why aren't those people turning up with something? Are those the people that are going to get young Alzheimer's? Are those the people that are going to get Parkinson's? So maybe that would take some of the emotion out of the problem.
Thanks, Bill. And this is a point I'll throw it open to anyone else who wants to comment on that. So, okay, go ahead.
Not quite sure how to turn this.
I'll just push the button.
The big button. Oh.
Oh, there you go. Is that it?
Yep.
Okay. Hi, my name is Laurel Rand. I'm a person with multiple sclerosis who has been denied access to vascular care in British Columbia. And I have a comment, and then I have one other sort of question that I'd like to throw out. Dr. Duncan mentioned that she asked in at a subcommittee meeting, the CEO of the MS Society, what they thought of the consensus paper of the International Society of Phlebologists. And they claim not to have knowledge of that. I am one of many, many Canadians who personally forwarded information to the, I'm just getting her title, to the Vice President of Government Relations for the MS Society of Canada. And I met her and told her that I was interested in CCSVI, and she looked at me and said that there has only been one study, at which point I told her that there had been many that I had actually read. And then I sent her a letter, several pages long, citing all of the studies, citing the paper that was put out by this society. That was, I think, in March. I asked her to distribute that to their medical advisory committee, and I asked her to include some vascular specialists on the medical advisory committee. So there are many, many documents that have been distributed by the MS Society and by the MS clinics in this province and across Canada. They're really, really easy to get. These are documents that appear to someone confused like myself to be a deliberate campaign by the MS Society and by the neurologists at the MS clinics to deny people with MS even access to the services of vascular specialists. That was my personal experience. The vascular specialist that I was referred to phoned the head of the MS clinic at UBC, and they decided together that I should be denied a consultation. So that's just my, we're talking about why these two things are married. From my perspective, it looks like a deliberate campaign. It is not a coincidental thing. It is not, and there's a huge, huge paper trail. So my question now, one of the things that I didn't hear is any discussion about activism, any discussion about how we can move forward and make a change. And so what I wanted to ask, and thank you, Dr. Duncan, for all the work you've already done, I'm wondering if you could please share with us, from your perspective as a politician, what is the single most effective action that we can take? So, I know writing to your MP is very important. Having done that, do we write a dozen letters to that same MP, or do we expend the energy trying to recruit a new person each week to send a letter to their MP? And maybe something entirely different from that. But if you could just sort of give us something
Something that we can do.
Hi. Oh, sorry. Can you hear me?
Press it again.
I just wanted to interject because thanks, Laurel. Your comments are greatly appreciated. But we have sort of an agenda that we want to get through, and you've kind of skipped right to the end, which is fabulous. But we kind of like to get there sort of the way that we want to get there, but we will get there. So we're just going to sort of put that in the parking lot for now, okay?
Yep.
Yeah, okay, it's
The red is on.
what I would like to discuss with you, I'm a former health professor. I've come to this 2.5 years ago. The world learned about this last November. I have a cousin with secondary progressive MS who went from perfect to quadriplegia in 5 years. And on leaving an MS clinic, we were quietly told, go to Italy and then go to Israel. Go to Italy was for liberation, although it wasn't called that then, and then to Israel for stem cells. And I think many of you will appreciate the first, with MS, you learn not to hope. There isn't the help out there, and there isn't hope. So I watched it. I'm a scientist. Where's the science? And then in February, I went to the first international conference at McMaster. And I have to tell you, I was impressed by the science I saw. I heard Dr. Zamboni, I heard Dr. Simka speak. And then I did what I do as a research scientist. You call the experts and you learn everything you can and you read what you can. And by the spring, I decided I have to chase this. And so, as many of you know, and we had incredible people who came and testified at subcommittee. We had Dr. Zamboni, we had Dr. Simka, we had wonderful patient advocates. There have now been 4 international conferences. I've been to 3 of them. I did not go to the 4th because it was 1 week separated. And I would like you to know the science that I know. I also want you to know I'm one of 2 people in Canada who's been to all those international conferences. And I can tell you who was and who was not there. So what is the current science? By last October, there had been 3,000 procedures done in over 50 countries. Dr. Zamboni has not changed his position since the spring. In the spring, he said we need more research, we need clinical trials, and the procedure, their data suggests, is safe. As I mentioned, Dr. Hakey has found 48 different abnormalities in the chest, neck, and spine. As you know, in Canada and in the United States, there are going to be 7 studies. They are correlational studies, 2.4 million. They are going to look if there is a relation between CCSVI and MS. I would argue that we are replicating what is already known. From those international conferences, Bulgaria, Canada, Italy, Kuwait, and the United States are all presenting the same data. And I have that information from New York at the end of July. What that data suggests is that 87 to 90% of MS patients show 1 or more venous problems. 1 or more. And that's shown with MRI or ultrasound. As you know, Dr. Simka has come out with the first published paper of 381 patients, 97.1% when angioplasty showed 1 or more venous problems. So you explain what is the difference between that 87-90 and the 97. Angioplasty is the gold standard. What they said in New York is about 1/3 seem to respond very well, 1/3 well to the treatment, and maybe 1/3 not at all. I think as we go on, because it's still a new procedure, we will learn that when you're able to say this venous problem can be treated and be able to target like that, the numbers may change. The point is, the drugs, if you have relapsing remitting, maybe reduce your number of attacks by 1/3. You have now 1/3 getting better, 1/3 better. That's better than our drugs. It is disappointing when I speak to high-ranking officials in Ottawa who say to me, yeah, but you can't do anything for primary and secondary progressive MS. I said, they are getting results with primary and secondary MS. I'm in touch with 1,000 Canadians across this country. I know many of you. Some of you email me every day. And I've talked to you before you've been treated and after you've been treated. I've followed over 200 of you. I've been asking since the spring that we have clinical trials. We have to do the research. But clinical trials have to include that treatment arm. And we need a registry. Canadians are going overseas. Why are we not tracking that data? When I spoke to a high-ranking official in July, I said, you have to track people because it's the right thing to do. You have to follow up. You have to make sure they're getting care here, one. And you also need to know if they're getting better at 1 month, 3 months, 6 months. The response I got is because we don't know what's being done overseas. And I said, that's not exactly true. For example, and I gave the example of Poland. I said, every patient who goes to Poland is first and foremost seen by a neurologist. They have an MRV, they have an eye test. They fill out a long, complicated form that's about 10 pages long, which does all their EDSS scores. Then they do the angioplasty, and there are pictures before the procedure, after the procedure, and by the way, there's actual video of the procedure. We know exactly what's being done. And I don't want to take up too much time. I just wanted to give you an idea of the science. And if you want to ask me about how many studies that have actually been done, how many show no response, what was difficulties with some of these studies, I'm happy to discuss it. People do not have the time to wait in MS. Time is brain. And taking 2 years to repeat correlational studies. We need to do clinical trials with the treatment arm, and I would like this to be seen in multiple centers across the country with real follow-up.
So the first question would be is who at the, who in Canada would be responsible for tracking the research, Kirsty? You say you're going to these conferences, but quite honestly, if there isn't a coordinated effort to make sure that your knowledge is now being funneled into something that can make a difference, then your personal knowledge is going to be lost, for posterity if you don't have a way to channel that to influence Canadian research, for instance, going forward, or perhaps the acceptance of international research, because does the research have to be done in Canada for Canadian bodies to accept it? So could you and perhaps anyone else that wants to talk to that is who in Canada would we look to? Given that we maybe don't want to be joined at the hip exclusively with MS, who would we look to coordinate the research going forward and to say, okay, we've got enough, now let's go, because we keep being told there's not enough research. So who's going to make that decision, and who's going to be informing the Canada as a whole about the research that's being done internationally?
Yeah, I think it's a real challenge nationally. We have, to a degree, we have examples before that have done this. We have the Heart and Stroke Society, okay? So the Heart and Stroke Society funded $1 million when we set up a Center of Excellence in Saskatoon. And at that time, there was probably 4, maybe 5 centers across Canada that were doing significant stroke research, and they interacted so they could get enough numbers to make a decision on what changes in stroke treatment really were and what mattered and what didn't. So that's a nice premise to have. If you stick with only MS, then we are, in the throes then of the MS Society, and right now we've got a very vehement opposition to CCSVI within that group. Maybe Kirsty can correct me if I'm wrong, but the closest you could come would be the Royal College of Physicians and Surgeons, which of course is a national body that licenses every specialist in the country. So that's everybody except the family medicine people with MDs. So perhaps there's a group within it that could look at neurologic issues and vascular issues as a composite. We don't have the paper trail for it. This doesn't fit under the Canadian Food Inspection Agency. This doesn't fit under any national body that I can think of.
since the spring is National Federal Leadership. This is a MS affects 75,000 Canadians across the country. And so we did have a take note debate in Parliament. And what was agreed at the end of that night was that the federal government had a role, provinces had a role, we had to work together, and we should move this along as quickly as possible. I will, before I talk about the process that has been set up and where I find that process challenging, I will point out some incongruences. I will take the example of Tisabri. Tisabri was fast-tracked in 2005, despite knowing that it could cause a fatal brain infection. As many of you know, there have been 70 cases and there's been 14 deaths. 75 is the new data? Thank you. Thank you. I checked 2 days ago. Knowledgeable crowd, which is what we need. In the spring, we had a new stroke busting procedure, tried in 27 patients, then implemented in 10 hospitals. We need evidence-based medicine in Canada, we absolutely do, but there are some incongruences here. So I've been calling for federal leadership. I would have liked to have seen clinical trials started across the country. There was a procedure set up. There would be this expert panel. And I have challenges with the expert panel. It was a panel with no experts. Who on that panel would have actually done the imaging? Who on that panel had actually done the procedure? And the reason we were told that they didn't want to include experts was because there was fear of biasing the sample. When you look at that panel, we know there were at least 2 who had vehemently spoken out against the procedure. There is an expert panel going forward. You should go onto the CIHR website and see who's on that panel. Who was carryover from the August 26th decision, who else is there. I know they've had their first meeting. That's the process that's been set up. I am going to continue to fight for clinical trials. When you can have a stroke busting procedure done in 27 patients and implemented in 10 hospitals, why is 3,000 procedures in 50 countries not enough evidence to do clinical trials?
I think we already have positive examples in Canada. Newfoundland Labrador is funding, so neurologists will evaluate someone before they go for their CCSVI treatment, and they'll evaluate them when they come home. You know, that's light years ahead of the rest of the country, but that is a very inexpensive thing to do. It even gives our burn neurologists more work. But it should be a very easy thing to do to tie in those from different parts of the country. As you know, Saskatchewan is working towards some of those. I don't think they're up to a clinical arm yet, but they're only 1 million people, not unlike Newfoundland Labrador, which is perhaps even a little smaller. But we need places like, there's no reason we shouldn't have in Alberta and BC and Ontario registries that can be set up so that these people are seen before and after. This is a very inexpensive happening. And the ministers of health of the provinces could probably bring it on side. I listened to the 6-minute discussion the other night with the CBC interviewing the Minister of Health in Saskatchewan, and he was pretty articulate about it. He understood what had happened to the fellow from Ontario that had died in Costa Rica, and he had a knowledgeable base. These people meet frequently. Maybe it's time that this is on their agenda so that there's a national registry. It's not a complicated thing to set up with today's interaction email. And so that each province takes responsibility to have their people assessed. And if you have a particular center in the world that you're not comfortable including, fine, but at least do it for the majority of them. It's starting to get very prevalent that people will go here into the United States. Surely some of these we can accept as being recognizable, especially when, as they do in Poland, they have the data, the video, before and after. These things aren't cooked, but they've got their own objective, before and after, as well as maybe 3 months and maybe 6 months. So it would be a very inexpensive way to have a parallel piece of research happening so that we could start some clinical trials which would allow a few people to actually have the procedure in Canada, and we could start to develop the expertise. Because right now, if you turn the switch tomorrow, we do not have the expertise among our interventional radiologists. We've only got 88 in the country. If you turn them all loose tomorrow, it would still take 10 years to do everybody here. So let's get it happening in several parallel pieces. The registry in each province, because we're going anyway, we might as well get documented before and after and start to find out what's happening.
Hi, my name's Ray McCoy, and it's really great to see you guys here. It's fills my heart a lot. One of the things that I'm thinking as I'm listening to you is that you're preaching a little bit to the choir here. And my question is this lady at the end is, this is all great, we've got lots of great ideas, but how in the hell do we make it happen? What do we have to do? Who do we have to kill? I don't know. Sorry, I shouldn't have said that, but you understand what I'm saying. What do we have to do? That's my question.
And we'll invite John Weston to make a comment.
Well, firstly, it's a great honor to be here, and I thank each person who's committed to find a solution to MS and to get to the bottom of CCSVI for what you're doing. I want to first confess my ignorance about the issue and let you know that I can at least say from my reading and from my discussions with Kirsty and other personal relationships that this is obviously an extremely important issue. But there's 35 other British Columbia MPs who are not here. And so why am I here? Firstly, I've got a great respect for Kirsty Duncan. And this goes to the questions that both of you raised, I think. Because in someone like Kirsty, what you have is a person with great expertise who is able to transcend party lines and to get to the bottom of a solution without making it an adversarial kind of a problem. And I don't know, I can't assess what Kirsty's advocating for. But what I can say is that if we can have people who are looking for a solution, can seek the solution, trying to find common ground and trying to maximize the expertise, get people like Dr. Code on a panel like this, then I think we'll get closer. The other reason I'm here is because of the hopes and the prayers I've expressed for my friend Derek to my right. And I think it often comes down to personal connections. I'm here because I know Kirsty, and I'm here because I know Derek. And it's a serendipitous thing that takes me out of all the things I'm supposed to be doing this evening to be here among the 36 British Columbia MPs. And I want to apologize that I have to leave early, but I just want to commend you for what you're doing and wish you great, speedy success in finding a solution that brings people together rather than driving people apart. Thank you.
So on the note of doing something about it, our next segment is on assessment, and I think everybody, when we first became aware of Dr. Zamboni's research, we're like, okay, then why, we need to be assessed for this problem, and I understand that there's some skill involved in the diagnostic. A lot of us in this room have been through it. There's some hit and miss with both ultrasound and MRI, and quite frankly, even or MRV as it's called in this case. There's some hit and miss going on there, but it is a start. And you know, I bet I could ask people to raise their hands. How many people had an MRI for MS before 1995, 1996? There were no available treatments for MS before about 1996 when the first trials of the DMDs started, and yet we were given very expensive MRIs to, and in the words of my neurologist, well, we'll give you the MRI, we can't do anything with it, but we might as well give you the test. But that is the exact reason that is stopping the testing for CCSVI, is they say we haven't got an approved treatment, therefore no testing. So who do we approach to get, because these technicians need to be trained. This is a provincial matter, I would take it, or is it VHA on the island or Vancouver Coastal Health? Dr. Coe, perhaps that's your area of expertise to say, how do we get something like this through the college, which we're writing letters. How do we, but why trials? That's for the treatment, Kirsty. We need assessment. If we've got clogged veins, we need to be assessed. There's no harm there. There's no risk to an ultrasound. So why can't we get another assessment on the block? And Cheryl, you want to speak to that first? Sure, go ahead.
Am I chomping?
Yes.
I'm just wondering if our guest from AIM Imaging could comment on that, if you're comfortable. Thank you.
Now, sorry, there were a few different questions raised there. Which particular comments would you like?
I think the question is how can we sort of get that sort of the assessment phase more out there in your community, so that you know, the radiologists and the technicians are going to be comfortable with that, or is that more private clinic stuff that's going on? And maybe you could introduce yourself as well.
Yeah, of course. Sorry. My name's Wayne Picker. I am the head radiographer at AIM Medical Imaging. So if you had your scan there in the past, I would have met you. In answering that question, my honest belief, having worked at Vancouver Coastal Health before, obviously the problem is that because the government isn't on board with supporting any imaging related to this, then nobody who is primarily working in the public health is going to get trained in doing imaging, which takes out 90% of people who are able to do this. So then you just have this subspecialty group of people who are working in the private system, and, sorry, I'm losing my voice, which my wife would say is probably a good thing. Us who are working in the private system, it's kind of been very similar to how everybody else has evolved with this. A lot of it's been trial and error. A lot of it has been researching how other people are doing. To be honest, water's not going to help, but thank you. I've been like this for about a week. And so, personally, I think that it is going to be a lot more research done from the technologists, from the radiologists, seeing what else is happening in the US, who obviously are supporting this a lot more. And yeah, it's just going to be, I guess, constant learning.
Do you think that with the within your community, with sort of the technologists and the radiologists becoming more interested, do you think that they can actually have some kind of positive effect on the government changing their mind? I mean, would they be part of sort of our group?
Well, again, speaking from our clinic side, where our scientific radiologist who works with us, he is very supportive of CCSVI. He's obviously researching a lot, and obviously the name of doctor, having anybody who's a doctor, as Dr. Kay would know, it adds a lot more warmth to anything you're trying to put forward. So definitely having a more, I guess, uniform effort from everybody involved in this is definitely going to help drive things forward to get things done in a positive manner.
And Laurel, you've got a comment?
Yeah, I did see a document that was circulated, I believe, by the MS Society that was sent to all of the private, or sent to a lot of private imaging companies, warning the private imaging companies of the dangers of providing ultrasound to persons with multiple sclerosis. And that was actually posted and is available on the internet. So do you think that's had an effect of making people more reluctant to provide these services to persons with MS? And just a secondary comment in terms of people keep asking who makes the decisions. My perspective is that the federal government and the provincial governments are taking advice from the MS Society, from that individual whom I met who was not aware of the research. And so that's where the block is happening. We have our federal and provincial governments taking advice from the MS Society and taking advice, I have it in writing from our Minister of Health in British Columbia, that they are acting on the advice of the neurological section of the College of Physicians. So if you could just maybe, sorry, I'm sort of muddied it up here, but if you could speak to whether or not private imaging companies have been scared off by the seeming campaign of the neuros and the MS Society.
Simple answer is definitely so. I remember, I'm not sure about the document that you mentioned, but I remember when this first hit the press in Vancouver in November last year, that if you like a leading authority on neurology in Vancouver and in BC was behind a fax that was sent out to all of the clinics I know in the Greater Vancouver area saying do not scan for this. And so obviously then you've already had people opposed to it, which if you're kind of treading the line of do I do this, do I not get involved in this, it's going to scare a lot of clinics off even being interested in doing this. From a personal point of view, I remember when this first hit the news and there was basically amazing figures from Dr. Zamboni of the percentage of people who had the blockages that had MS, which to me seemed like an incredible number. I think it was either 100% or extremely close to that. From somebody who's involved in research in the past, it obviously makes you a little bit concerned when the figures are so fantastically ideal. And so I remember my personal stance was, well, I'd like to see a bit more research on this. And sure enough, within weeks, we'd all seen a lot more research was currently being done in Buffalo at the time, and basically around the world. And soon, my personal stance changed from let's wait a bit longer for more research to why isn't something getting done about this a lot sooner? And a year on, we're still in the same position.
What's your personal results that you've been finding?
I would say that statistically it is very similar to the Buffalo results. So at least 7 out of 10 patients with MS seem to have some form of narrowing or blockage in either the jugular veins, the transverse sinuses of the brain, or the azygous vein in the chest. So it is very similar results. And we've also scanned a few healthy subjects who were either involved in the clinic or kind of friends of ours, just to get an idea of the percentage of people who also just coincidentally have these blockages. And we've probably found about 5 out of 15 or 20 patients who we've done in that regard. So again, it's close to that 22% figure that has been released from Buffalo as well.
Thank you. Just a couple of things. I'd like to names. I like the person who was at the MS Society. I'm really curious. This Vice President, what was her name? You've had many conversations with her?
Oh, the Vice President of Government Relations. I can't think of her name right now, but if you, I'm happy to provide it to you. I'm happy to share copies of the letters that I sent to her.
Fantastic. And also this neurologist, a leading neurologist, what was his name?
To be honest, I don't think it would be appropriate for me to divulge the name. I can say that he works as part of the UBC MS group, but I would not be allowed to say his name.
I'm sorry, was it not public knowledge, or was it not a public document?
Well, again, because it was sent to each of the clinics warning us against it, I'm not sure the exact light that he was trying to get across his point, so I wouldn't want to be...
Someone here would know, maybe?
Offline?
Offline? Okay, thank you.
So sure, if you want to exchange the communication that you're doing, let's do that into the reception part rather than this part. I think Dr. Code wants to speak to the assessment and the radiology issue here.
Well, I think the assessment issue is really important. It must be something contagious. I mean, I'm losing my voice too. But anyway, the fear-mongering that's happening currently is a very real thing. I mean, there's letters been sent out in Alberta. I'm not sure exactly the same ones went here, but in Alberta, the general practitioners were sent letters saying they must not send MS people for ultrasound. And that letter went out about 6 weeks ago, all right? Unfortunately, the College of Physicians and Surgeons in each province has licensing capability. And if you lose your license, you lose your total income. I mean, they have huge power. And unfortunately, they are also willing to toe a line of economic walking in one way only, or listening to one group only, and they mandate that everyone should walk that road. So I think it's been a huge stumbling block for the radiology people, for the investigation people, for the interventional radiologists. I mean, the fellow had major threats against his license when he did a couple of procedures in Victoria. I mean,
Can I just ask, Bill, when you say economic, are you talking about the bubble of 75,000 of us that are going to need scanning and that are going to tax an already overburdened system if the colleges of the provinces said go? I mean...
No, I'm not. I'm talking about the fear that they engender in the physician's head in that they'll lose their license if they don't toe the line. This is not far from a police state. This is a really sad state of affairs.
And Dr. Duncan, you wanted to speak to the assessment issues that we're having and maybe give us some solutions?
Thanks, Sandra. This is a really good discussion. I'm going to try and pick up on a number of points. I will come back to the issue of the registry. I'm in touch with a number of physicians who have been treated. And they have said to me, if they're in actual tracking, would we still be calling this anecdotal evidence? That's important. There is absolutely a learning procedure to this, both in terms of the imaging and how you do the imaging. Is it Doppler? Is it MRV? Do we use something else? Do we use Zamboni's protocol? Do we use Heikki's protocol? Do we also look at iron in the brain? Do we look at flow in and out of the brain? There are many different things we can be doing. That needs to be standardized. I wonder what happened to the $10 million. The MS Society had asked that $10 million be earmarked for trials of CCSVI and MS in the spring. In the spring, I tried to get that information at committee. I did not get an answer. I asked the same question again yesterday at committee. And at this point, the answer is no. I am hoping that we know there are more trials coming on board in the United States. There's more trials coming on in Saskatchewan. And as many of you know, the neurologists are admitting their patients are getting better. We saw that on the weekend. Dr. O'Connor wrote, patients are getting better. The patients are getting better. Why aren't we doing clinical trials? I do want to talk a bit about, if we look back to ECTRIMS, I think this year there were 14 papers, 10 or 14, that dealt with CCSVI and MS. And we can go, I don't want to take the time to go through what each of those papers said. The only review that was done for the August 26th decision was a review of the published literature. I'm a scientist. It's not how we do science. We also look at the gray literature, for example. In the gray literature, it would be what governments produce. But it matters who you bring in the room. It matters what questions you ask. It matters what data you collect. I would like to know why you didn't go to the top experts, why you didn't talk to those practicing in the different countries. Ask them how they're doing, what their results are, what their follow-up is. Those are important questions. They looked at 7 papers. 2 of those studies, and I know you know this, they were published in 6 weeks. Since when does a scientific paper go through in 6 weeks? Not very often.
All right, and just, could I ask Wayne, the radiologist from AIM there, no, I just want a quick question. How many radiologists are capable of doing what you're doing if all else being equal across, you know, pick a place, Vancouver, Canada, whatever data you have, how many of you are there that could do this? And how long would it take to train somebody who has your basic background?
Okay, first thing that I should point out, I'm not a radiologist, I'm a radiographer. The difference is obviously specialist doctor as opposed to me, who I'm trained Bachelor of Applied Science in Medical Imaging, so I take the pictures. So it is a common kind of misunderstanding with that. But as for taking the pictures, ultrasound and MRI are the 2 different ways that the data is actually achieved. Ultrasound is a modality which is known to be very user-dependent. It means that you need to know what you're doing with ultrasound, which is why our opposition, other imaging clinic in Vancouver who are doing these imaging procedures, have had their technologists actually go elsewhere for training, is to make sure that the standard of imaging is adequate. And from what I understand, obviously it is adequate. We all want to make sure that we're doing the best thing by the patients, and so with ultrasound, they're making sure they're doing that. We're doing ours with what they call flow quantification MRI. If anybody who was at the meeting last week at the library with Dr. Hewitt from somebody interventionalists, he spoke about...
Specific interventionalists,
Thank you very much. He spoke about the fact that they solely use flow quantification MRI. The fantastic thing about that is that it is less user dependent. Basically, if you can do MRI scanning, you can do the flow quantification data acquisition. It's the analysis part which you need somebody specialised. Excuse me. So for that part, basically the MRI side of things is pretty standard. The ultrasound is a lot more user dependent. So being able to do it, if the person is trained in ultrasound and is trained in vascular, so Doppler ultrasound, and is trained by one of the experts in the field on looking at the venous system, then that's what they would need to do that. For the MRI side of things, if the machine has a flow quantification capabilities, basically anybody in Greater Vancouver who does MRI would be able to get the pictures for that. Then it's down to the radiologist to interpret them.
Oh, there's a question. Where's the next question?
Sure.
It's me. Okay, go ahead.
I have a question, and it sort of looks at both the research and the assessment combined in a 2-tiered kind of way through my own personal CCSVI journey, I guess. One of my questions is, why is it that we're hailing clinical trials to be dealt with here in Canada when there already are all of these studies to reflect upon and look at internationally. I don't think that Biogen or any of the other MS drug companies have to go through clinical trials in every single country, including our own, before they get to be sold on the market. And secondly to that, in terms of assessment, I understand the ultrasound and MRI and the flow quantification is important. However, I'm one of those rarities that I came up as a negative, and then upon having a venogram, turned out to have a 75% blockage in my jugular vein under my clavicle bone where it wasn't detectable. So I'm wondering if that is going to give us the clinical data, so to speak, in terms of assessment and registry and numbers, that really is quantifiable and accurate.
Well, just let's respond to part of that. I would rather we did not look at CCSVI the same way as we do drugs. Drugs are very different. Drugs have their own protocols, the double-blind control trial, gold standard, which was developed for drugs, but does not apply the same to procedures. You cannot do a true sham for angioplasty. I mean, any of us can figure it out once we talk to anybody that had one. So please don't put it in that box. In reality, each of those drug companies must redo those studies in each country that they're released in. Okay? So please don't go on that ground, because it's a place where you're going to lose for dollars, big time. But because we're talking about that set of drugs, if people are going to talk about research, we have to start talking back to the neurologists about research, because now after 10 years of using those drugs, they don't work. So after the 2-year trials suggested that 30% improvement occurred, but as the smoke was cleared after 10 years of data, they're not working. So I think we have to fight research data with research data. They can't say that, you know, this is the gold standard and we use these because it hasn't proven it. They have to look at all the modern data too, not just what they were learning 6 and 8 years ago. So I think if we divorce those two, then we can start to look at, now MRV would have picked up your challenge, ultrasound would not, because it's behind the bone. So I think the screening, I suspect, is going to be ultrasound. It's a lot less expensive, it's a lot more accessible. And then if ultrasound is negative, meaning you do not have an issue, then that subset should probably go on to MRV. Now, and then they need to be well trained. And the woman who trains most people in Canada about it is actually a Canadian from Port Colborne, Ontario, who works in Buffalo. And she's trained sick kids, she's trained people here, she's trained people in Saskatchewan. So there is good training to be out there. It's very inexpensive to send your people to there or have that person come here. So we have to start looking at solutions as we look at this. So if we try and make it CCSVI, follow-up and evaluation, let's look at it as a stepwise thing. Well, let's not bar people from MS from having an ultrasound, but if the ultrasound is negative, then they may need to go on to MRV if they're still passionate on their journey.
And on that note, you know, we have, you know, like you said, a 75,000 person bubble that has to go through the system, and with Sherry's experience, I mean, you know, most of us have had the line given to us that, you know, I'm not going to prescribe this until I get a positive test result, you know, with a drug or whatever. That, you know, doctors are reluctant to act until they have the test in hand that says you have it. So, given that venograms are an assessment tool, they're more invasive than an ultrasound, but why, you know, I know a lot of the treating doctors, and hands up anyone who's been treated whose doctor said this, that you can go straight to venogram and bypass the MRV or the ultrasound. You know, in Cher's case, the venogram was the diagnostic tool. It just happens to be at the point of treatment that she was assessed. It's unfortunate that 2 assessment people in the room are both losing their voice, so I don't know if Dr. Duncan, you could speak to that, but how do we then get the medical system to change so that we don't have to pass the test with the MRV, because there'll be people with MS or CCSVI that will fail the MRV, will fail the ultrasound, but who nevertheless have a blocked vein that could be diagnosed with a more invasive but more accurate venogram.
Well, I think you've got a competition going on right now. See, neurologists do not do procedures. Cardiologists do. Cardiologists can look at a vascular diagnosis and do every day. That's their bread and butter. However, neurologists, the biggest procedure they will do is a spinal puncture. And they do those with huge needles. I'm regretful to say, as an anesthesiologist, my sister suffered for 2 weeks after hers. But anyway, the piece that we need to do is venogram will not become commonplace because the neurologists still think it's an extremely invasive entity. The other challenge we have, though, we still don't have the people that can read it to say what normal is and what a challenge is. So I think it's going to muddy the waters. So we're going to have to find more people to do the intervention. So I think we're going to end up investing either in cardiologists or neurosurgeons or vascular surgeons, but more than interventional radiologists. But, you know, we're trying to figure out the path here. And really, assessment, you know, I think is a stepwise thing. But first, we've got to get the angst, the emotion out of the issue. So we need to look at the venous issue, CCSVI. What could it be predicating beyond? Because I'm now talking to people with Parkinson's and Alzheimer's of unknown origin. Rule out chronic Lyme, but then get on with it. Maybe you'll fit in that group. And if you've got nothing to lose, you should look at it.
Just, if I can just respond to that a little bit. I totally and utterly agree with what you're saying, Dr. Code, and you're right, it wasn't a fair bubble to put, you know, drugs and procedure into the same place. At the same time, I will say from an MS point of view, in terms of getting MRI assessment, and also with a father with pretty advanced Parkinson's disease who's in a full-time care facility right at this moment in time, I would say that I think this is the lineage that we share in terms of our genealogy, and I look forward to that being proven as research goes down the line. And I think that's more to my point, is why do we have to repeat research that has already been established internationally? Why can't we get to a point where we start doing some groundbreaking research to figure out more of the ins and outs and whatnot? And also to the point of the MRI, MRV situation, I've been waiting 1.5 years to have an MRI just to measure the lesions that have changed since my last MRI, which was 8 years ago. So I don't know that that is the answer either.
And I appreciate you sharing that personal experience, Shara, because we've all been there. Anyone with MS has been in that wait list. I do want to get back to an emotional issue. Unfortunately, Bill, I know you said we need to take the emotion out of it, but I know we're looking for solutions here, and one of the solutions that I think we need to talk about, how do we get treatment, not only generally for all of us here, but also on compassionate grounds, which there have been many precedents in Canada for individuals getting treatment on compassionate grounds and usually that means access to drugs, experimental drugs, and so how do we move beyond this debate that we've got about evidence-based medicine into saying, okay, what about people who have no medical options, the people who've run out of drugs, who are offered nothing else? How do we get those people front and center and get them treated on compassionate grounds?
So that's the group that has nothing left to lose. Because that's a group that we investigate very rigorously sometimes. it's usually someone that's incredibly important or connected to someone that's really important, you know, in the public's eye. And so that means, you know, the person is dying of cancer, so we can try this original reason. You have the option in Canada as a physician to request an experimental drug to be used in an individual case. However, it does not apply for a procedure. So that's a challenge. Okay, we have the system set up for drugs. And maybe we can list a whole host of reasons why that might be the case. But you can get an experimental drug, but you cannot get an experimental procedure. We need to take this away from being an experimental procedure. And I didn't bring up Parkinson's and Alzheimer's casualty. We need some friends out there. We need more people passionate.
Yeah, go ahead, Kirsty. Oh, Bev? Yes, go ahead.
I'm just wondering if the DDS surgery in the year 2000 being used on somebody with MS, was that not kind of considered experimental? And it was surgery? That's what I was told.
Can you describe it, because I don't recognize that? I mean, I get really upset when people have 1 of 10 or 1 of 12 die of stem cell transplant for MS.
Sorry.
I mean, we lost 1 of 12 people.
Oh,
with
DDS
stem cell
surgery, that's deep brain stimulation, is what Michael J. Fox had for Parkinson's.
Okay.
So it's electrode in the...
Yeah, no, I know exactly what it is. It's the acronym
So,
that is.
a neurosurgeon did that on my son to try to calm the tremors, and we were told that it was kind of experimental, and he was the 4th person to have it, MS person to have it done. So I just thought that sounded like maybe...
Well, yes, and we had some interventional radiologists willing to do that, and there have been a number have done it on MS people because they felt comfortable doing it. But right now we're caught in the throes of backlash from a subset who's holding the rest of medicine reins. So people can't even do that anymore because they're under threat from their college to take away their license. That's why we're stuck right now. We're in a bigger hole than we were a year ago because we polarized.
Go ahead, Braden.
So how do you break that deadlock? I would like to ask.
I think maybe that's where we need to move in this whole debate is how do we break the deadlock? Everyone here has written countless letters and emails and phone calls and gone to meetings, and I applaud your efforts. But how do we move it forward, Kirsty?
Dr. Duncan, what's the roadblock? I mean, you know, can you give us any clues from your perspective what the roadblocks are? What are we fighting against?
I think Dr. Code has mentioned several of those roadblocks. I think the process that's been put in place is challenging. I want to recognize everyone in the room because you are the heroes here. The work you have done to highlight this over and over again. The petitions you fill out allows us to stand up in Parliament and talk about this. I want you to know I've got the head of CIHR coming in a few weeks back to the subcommittee so we can ask questions. We just got that passed. We have lots of them, Sanders says. I would like to share something, and I would never share someone's name, but I think she's known to all of you, Barb Farrell. Yeah. Well, and her husband's given me permission to use her name. He had asked me to come see her the day before she was medevac to the United States. And I'm always leery to tell her story because I would never want to hope-monger, ever. I'm a scientist, I will give the facts. But you also have to know there are people who are getting better. And Barb was, as you know, in palliative care on a feeding pump, on a morphine pump, immobile, and she could barely whisper. Her husband emailed me the night of the procedure to tell me what had moved. I went to see Barb 2 weeks after the procedure, and she was sitting up in bed. I couldn't believe it, and I said, Barb, how are you? I didn't even know if she would know me, and she said, I'm happy, with a very strong voice. And I said, Barb, why are you happy? And I will take this to my grave. She said, because I sound human. Barb came home 2 weeks ago. Barb is living at home with her family. Barb is months off the morphine pump. She is moving her limbs. She's swallowing. She's eating, and Barb can write her name. And as I said, I don't want to hope longer, but I know how many of you in this room rooted for Barb. And I know how many emails I got saying, why aren't you doing something? And her husband says, you know, tell her story. And when I've been at these various conferences and it's come up, you know, the EDSS scores don't improve. Well, she's improved 1.5 EDSS scores, and she'd be a heck of a lot more. But the way the EDSS scores are set up, you know, it's mobility. And perhaps we need to be looking at other ways of measuring this. And I'll let someone else answer, and then I'll come back to how do we move this forward. I think the most important is we've got to bring the groups together. There's so many people advocating across the country. You need one voice.
I just wanted to add something to that. I had a very, not a long week, so I can't think of the word, but a very positive email from Janet Palm, who is the president of the MS Society for BC and Yukon. And she extended an olive branch, I consider, to meet with our group here to talk about how we can work together. So I know that we've all had a real challenge in the past year, and you know, we like to point fingers and we like to talk mean about what's going on, but I think Kirsty is absolutely right, is that we need to have one voice, and we have to start playing nice, and we all have to play in the same sandbox in order for this to move ahead. And I'm very appreciative that Janet Palm did reach out, and I'm hoping that that is going to move this forward in the direction that we want it to go, because, you know, as we've heard tonight, you know, the MS Society seems to have been a roadblock in this whole process. Whether or not that's true or not, I'm not here to take sides. I'm here to move this forward, and I'm very hopeful that that's what's going to happen with Janet and our group, and all of you as well.
Okay, first Laurel, and then back to Bev, and then Duncan. I think that's probably all that we're going to have time for. Those three.
I'll be as quick as I can. I think that yes, the one voice is the way to go. I appreciate the let's play nice perspective, and I have a certificate in conflict resolution, and boy did I try and play nice with the MS Society. Deanna Grotzinger, I can't spell it for you, is the name of the VP of Government Relations. We pleaded with her, we met with her. A gentleman with MS in Toronto organized meetings at his own expense and begged and pleaded on our behalf. This has been going on for months. So I think that the way that we're going to move forward is sadly going to be litigation. I think I've heard of two groups. Today there was a conference by a group out of Toronto called Angioplasty for All, AFA. they're moving forward. They're moving forward with a lawsuit. They said that they have specialists to give expert witness. They were looking for a neurologist, so I'm happy to hear that some neurologist somewhere has spoken out about improvements. And the other group is Joan from California, whose husband, Joan Deal. So apparently, I've read postings recently saying that they're going to initiate some kind of legal action. Sadly, I think many of us across Canada have huge bruises on our heads from slamming it against that wall. Kirsty, Kirsty has managed to bring this forward into the public eye, but it seems like we're not going to get a political solution. It seems like litigation is going to be the way this has to go. There has to be some actual liability before people are going to back down and say, yes, persons with MS in Canada also have the right to have a vascular consultation when they have clear evidence of a vascular condition, or a strong suggestion that they could have a vascular condition. So,
yeah, Laura, we have to wrap up because our reception's going to start here. I'll call on. I'm sorry, I don't know your name. I know you came with Sharon.
Hi, my name is Marilyn Lenson, and I'm here from the MS Society. I am a national board of director. I am the chairman of the BC Board of Directors. And I've sat here silently, and I think there's been a lot of really good points brought forward. We have a unique situation, but I think thinking out of the box, as Bill said, you know, we have to look at the way other things are done and how do we bring this forward. And at the MS Society, we do want to bring it forward. I mean, our mandate is really to help people with MS. And I'm here to listen to what you guys have to say.
Beth, do you still have a comment? It would be really brief because our catering is going to get cold in a second.
I just wanted to add to what Cheryl said, that back in February I wrote to Janet Palm. Actually, I wrote to the MS Society explaining how I thought they had failed us, not expecting any response. And Janet Palm actually phoned me, and we talked for about half an hour. We still saw things from different sides, but just the fact that she has, as you said, put out an olive branch, maybe. I mean, I'm supporting the litigation in Ontario financially, because I believe, as Laurel said, that might be an avenue. But I really appreciate the fact that if an olive branch is out there, perhaps Janet Palm actually has some concern, but being placated by them and saying that they want to help us is very hurtful, because they have not done that so far. So I have hope. Thanks.
And Duncan. I'm sorry, Derek.
It's actually Derek. Quickly,
Yeah.
lots of moving parts, tremendous, all sorts of words been spoken. What I don't have is when if I want to rush forward, I don't have a sentence. In 1960, a president of the United States said, we want to put a man on the moon by the end of the decade. We want to put a man on the moon by the end of the decade. Extremely clear. Do we have a one-sentence clear statement as what we want to do? So we can all get behind this statement and make it happen. This is something I haven't heard, and it's been a real struggle because I can't seem to get my hands around what we want to do. So thank you very much. Just get that one statement. If we could come to anything, that would be, I think, a very, very powerful place.
Well, the nice thing about having foul weather is that we've got a small enough group that as we retire to the reception up there, I think let's work on that and let's continue this conversation outside in the reception and stretch our legs. And there are going to be chairs out there. And at this time, I'd just like to thank everybody for being here and for participating. To Dr. Duncan, of course, and Dr. Code, to Wayne with your voice, and everyone else here up on the panel here, as well as in the audience. This conversation is an important first step, and we are going to carry it on. And like I said, we're a small enough group that, Derek, your question is one that let's continue that and many others as we move forward and help Kirsty in her advocacy on our behalf. And also we are actively engaged in this. We're not going to just sit back on the sidelines, you know that. Okay, so thank you everyone. So shut off your mics, and all the food stakes out in the wooden section, please. And Cheryl just wants to say something quickly as well.
If anyone heard my phone beeping up here, I was madly texting Dr. Godley to see what had happened to him. And he's ferociously working on his study at the False Creek Surgical Center. So he wasn't able to make it today, but he wanted me to let you know that by Sunday, they will be finished all their clinical patients for the study. So that's excellent news.